Hello and welcome to NCLEX Made Simple YouTube channel. This is a place we make sure that we give you NCLEX content in a simple, elaborate and articulate manner so that you can be able to take a good grasp of this content and help you in the NCLEX exam, help you pass the NCLEX exam within the very first attempt. So today, I'm your presenter Martin M. Gitao, and I'm also here with Hirale Muturi. We are both RNs, and we are going to help you with our topic today, which is fluids and electrolytes. The first thing that you need to understand about fluid and electrolytes, they are general concepts. So with fluids and electrolytes, we look at the intake and the output, and when they do balance, that's what we call a fluid balance. If they don't, then you end up with a fluid excess or fluid deficit. When there's a fluid excess, you could be having problems like bounding passes, hypertension, jugular vein distension, and even edema. Also, in urinary system, there could be good urinary output, pale and dilute urine, and also weight gain when the fluid is too much in the body. When there's a fluid deficit, there's not enough fluid in the blood vessels. Here we can have weak passes, hypotension, poor skin turgor, and in renal system there is a poor urinary output, dark concentrated urine, and weight loss. When you're covering imbalances, you have to look at the sensible losses. This is what we can see in the urine during urination, defecation, and wood drainage. Then we have fluid loss, what we call insensible losses. This is evaporation from the skin and respiratory from the lungs. Now when you look at the distribution of fluid by compartments in the average adult, 70% of it is intracellular and 30% is extracellular. This extracellular fluid can be interstitial, which is at 22% between the tissues. Intravascular inside blood vessels, it is at 6%. And transcellular is like a cerebrospinal canal, lymphatic tissue, synovial joints, and even inside the eye. This is at 2%. The other thing is age-related total body fluid. For a full-term baby, the total body fluid is 80%. For a lean adult male, is at 60%. Aged client, they are at 40%. So you find that because of these percentages in a full-term baby, the infants and the older adults are at a high risk for fluid-related problems. Fluid and electrolyte transport. We have passive transport system and active transport system. Passive transport system is diffusion, filtration, and osmosis. But for the active transport system, this is like pumping, and it requires expenditure of energy. That is ATP. In diffusion, molecules move across a biological membrane from an area of higher to an area of lower concentration. In filtration, movement of solute and solvent across a membrane caused by hydrostatic or water pushing pressure. It occurs at the capillary level, and if normal pressure gradient changes, as occurs with right-sided heart failure, edema results from blood spacing. In osmosis, movements of solvent from an area of lower solute concentration to one of higher concentration. It occurs through a semi-permeable membrane using osmotic or water pooling pressure. Now let us look at active transport system. And here we said it requires expenditure of energy. It's also called pumping. The solutes can be moved against a concentration gradient, and it is dependent on expenditure of energy, that is ATP. Osmolality is the concentration of a solution expressed as the total number of solute particles per liter. So when you are looking at the term as osmolality, you have to ask yourself how much stuff is in this fluid per liter. That is osmolality. Water osmolality is at 306 milliosmol per liter. Urine osmolality is between 300 to 900 milliosmol per kg in water. And serum osmolality is at 285 to 295 milliosmol per kg in water. The other thing to keep in mind is the specific gravity. This is the ratio of the density of a substance to the density of a standard, usually water, for a liquid. How much stuff is in this fluid compared to water? That is the specific gravity. You ask yourself, how much stuff is in this fluid compared to water? For example, water specific gravity, we know it is 1. So when you look at the urine specific gravity, we are looking at how much stuff of this urine is compared to water. So urine specific gravity is 1.005 to 1.030. That's the normal urine specific gravity. The other term we need to learn is tonicity. Tonicity is the concentration of a solution as compared to another solution. Concentration of a solution as compared to another solution. So what does this mean? How much stuff is in this fluid as compared to something else? How much stuff is in this fluid as compared to something else?
Welcome again. This is Mr. Muturi. The topic is fluid and electrolytes, and now we are going to do a review of the fluid types. And basically, we have 3 types of fluids, which I need you to know for the purpose of the NCLEX. We have isotonic, hypotonic IV fluids, and hypertonic IV fluids. Isotonic IV fluids, these are IV fluids with osmolality similar to brand. The osmolality is similar to brand. That is for isotonic IV fluids. Remember osmolality, we defined osmolality as the concentration of a solution expressed as the total number of solute particles per liter. Remember that. What did we define as osmolality? Is the concentration of a solution expressed as the total number of solute particles per liter. So we are saying isotonic IV fluids are IV fluids with osmolality similar to brand. These fluids do not cause a fluid shift because solutions are equally concentrated. They do not cause a fluid shift because solutions are equally concentrated. What are some of the examples of isotonic IV fluids? Here we have the sodium chloride, the 0.9% sodium chloride. We have lactated ring gas and the dextrose 5% in water. The dextrose 5% in water, it is technically isotonic, but it becomes hypotonic once in the body. The 5 in water before, when it is in the shelves, when it is in the medication carbons, it is technically isotonic. But once it's in the body, once infused in the body, it becomes hypotonic. Remember that. So what are the uses of the isotonic IV fluids? Some of the uses of the isotonic IV fluids, we use them to increase the intravascular volume. We use them for blood loss, sodium chloride. For severe blood loss, we infuse a patient with sodium chloride. For surgeries, preoperative free, we preload patient with sodium chloride, lactated ring gas. We also use them for isotonic dehydration when there is fluid loss, sodium chloride, lactated ring gas. We also use them as maintenance fluids, and we also use them on patients who are NPO, near pahoro. We now look at hypotonic solution, or what we call hypotonic IV fluids. Hypotonic IV fluids, as the name suggests, hypo. Their osmolality is lower than the brand. Their osmolality is lower than the brand. Hypo, lower. Their osmolality is lower than the brand. These fluids, they move fluid out of the brand vessels into cells and interstitial spaces. They move fluids out of the brand vessels into cells and interstitial species. They have lower solute concentration. Hypotonic IV fluids have a lower solute concentration. Fluid shift from hypotonic solution into the more concentrated solution to create a balance or to create a balance. Some examples of these fluids, we have the half normosaline or 0.45% sodium chloride. We also have what we call 0.33 or 0.2% sodium chloride. Dextrose 5% in water. Remember, we think it is technically isotonic. But once in the body it becomes hypotonic. We also have 2.5% dextrose in water. It is 2.5% dextrose in water is technically isotonic, but it becomes hypotonic once in the body. Some of the uses of hypotonic IV fluids, we use them in conditions such as diabetic ketoacidosis, with patients who have HHNS, hyperosmolar and ketotic syndrome, and we also use them with patients who have a higher sodium levels in the body, or what we call hypernatremia. Hypertonic IV fluids. Our third type is hypertonic IV fluids. As the name suggests, they have a higher osmolarity than brand. They are IV fluids with osmolarity which is higher than the brand. They move fluids out of cells and interstitial spaces into the brand vessels. That is, basically we are seeing they have a higher solute concentration. Fluid is drawn into the hypertonic solution to create a balance. And some of the examples of hypertonic IV fluids, we have 1.5%, 3% or 5% sodium chloride, dextrose 5% in normosaline, it is also hypertonic. Dextrose 5% in ringer's lactate is also hypertonic. Dextrose 10% in water is also hypertonic. What are some of the uses of hypertonic IV fluids? We use them when a patient has lower sodium levels, what we call hyponatremia, and also we use them when a patient has cerebral edema. We now look at regulatory mechanisms in the body. How are these fluids regulated in the body? We have 4 regulatory mechanisms. We have baroreceptor reflex, we have volume receptors, we have renin-angiotensin-aldosterone mechanism, and antidiuretic hormone. For the purpose of the NCLEX and in this topic for fluids and electrolytes, we will recover renin-angiotensin-aldosterone mechanism and the antidiuretic hormone. The renin-angiotensin-aldosterone, I would start with that. Renin, what is renin? Renin is basically an enzyme which is secreted by the kidneys when arterial pressure or volume drops. Renin is an enzyme which is secreted by the kidneys when there is a drop in arterial pressure or volume drops. Renin, it interacts with angiotensin to form angiotensin 1, which is a vasoconstrictor. Remember that. Angiotensin 1 is converted in the lungs to angiotensin 2 using the angiotensin converting enzyme. This process will produce vasoconstriction to elevate the blood pressure. It will also stimulate, and angiotensin also stimulates adrenal cortex to secrete aldosterone. Aldosterone is a mineralocorticoid that controls sodium and potassium blood levels. It also increases the chloride and bicarbonate concentrations and fluid volume. Aldosterone. It is a mineralocorticoid which controls sodium and potassium levels in the blood. And we are also saying it also increases the chloride and bicarbonate concentrations and also the fluid volume.
The other regulatory mechanism is the antidiuretic hormone. It is also called vasopressin. This hormone is released in the posterior pituitary gland, and this is in a bid to restore intravascular fluid volume. This release is triggered by osmoreceptors in the thirst center of the hypothalamus. So when there is a fluid volume excess, you expect less antidiuretic hormone to be released. But when there is fluid volume deficit, that is when the antidiuretic hormone release is increased in a bid to restore intravascular fluid volume.
Let us now look at fluid imbalances. We have 4 types of fluid imbalances. We have dehydration, hypovolemia, hypervolemia, and the 4th type is water intoxication. Dehydration, this is loss of body fluids, which will lead to increased concentration of solutes in the blood and a rise in the serum sodium levels. What is basically happening in dehydration is that the fluid shifts out of the cells into the blood to restore balance, so the cells will shrink from fluid loss and they can no longer function properly. The clients who are at risk for dehydration are clients who are confused, comatose patients, bedridden patients, infants. They are also at risk of fluid dehydration, and the elderly and the entirely faint clients. Clinical manifestation of dehydration. How do these patients present? They present with irritability, fever, confusion, dizziness, weakness, extreme thirst, decreased urinary output. They have a dry skin or mucous membrane, sunken eyes, poor skin turgor, and they also present with tachycardia. How do we manage dehydration? The management of dehydration, fluid replacement. You can do oral or intravenously over 48 hours, monitor symptoms and vital signs, maintain intake and output, maintain intravenous access, do daily weights. Remember, when doing daily weights, same clothes, same time, and same scale. The 3S for daily weight, same clothes, same time, and same scale. You can also do the skin and mouth care. Another fluid imbalance is hypovolemia. In hypovolemia, we basically have isotonic fluid loss from the extracellular space, and hypovolemia is bad because it can progress to hypovolemic shock. What causes hypovolemia is caused by excessive fluid loss. This can be as a result of hemorrhage. We have also decreased fluid intake, can also lead to hypovolemia. And that space, that is fluid shifting, can also lead to hypovolemia. Clinical manifestations of hypovolemia, we have mental status deterioration, thirst. They also present with tachycardia, delayed capillary refill. Hypovolemic clients also present with what we call orthostatic hypotension. They also present with urinary output which is less than 30 ml per hour. They also present with cool pale extremities, and they also have weight loss. How do we manage hypovolemia or do fluid replacement? They have done spacing, also do albumin spacement with done spacing. Clients or patients, they lose their albumin. You can do also blood transfusion for hemorrhage. You can also give them dopamine to maintain blood pressure. We can also have them wear masked trousers for severe shock. You can also access for fluid overload with treatment. Remember to access for fluid overload with treatment. Let us now look at hypervolemia. Hypervolemia, this is where we have excess fluid in the extracellular compartment as a result of fluid or sodium retention, excessive intake, or renal failure. It occurs when compensatory mechanism fails to restore fluid balance. That is how hypervolemia develops, when compensatory mechanisms fail to restore fluid balance. What are some of the clinical manifestations of hypervolemia? A client with hypervolemia will present with tachypnea, dyspnea, crackles. They also represent with rapid boarding pass. They also represent with hypertension, and they have the S3 gallop, which is the third heart sound. They also present with increased intracranial pressure, pulmonary increased CVP. They also present with pulmonary artery pressure, and pulmonary artery wedge pressure is also increased. They also present with jugular venous distension. They have also acute weight gain, and they will also present with edema. Let us now look at edema, which is part of hypervolemia. Edema is fluid which is forced into tissues by the hydrostatic pressure. Edema is first seen in dependent areas, We have anasaka. Anasaka is severe generalized edema. We have pitting edema and pulmonary edema. An important point I would like you to note is that a client with acute kidney injury or chronic kidney disease is at high risk for fluid volume excess, or what we call hypervolemia. How do we manage hypervolemia? Fluid and sodium restriction. Restrict this client from taking excessive fluids and sodium. You can also give diuretics to eliminate the fluids. Monitor vital signs. Do hourly input and output. Monitor the breath sounds. Monitor also arterial blood gases and labs and laboratory values for the test that this patient is undergoing. Elevate the end of the bed and give oxygen as needed. Remember, we said some can exhibit pulmonary edema. Maintain intravenous access. Daily weights, remember daily weights, same scale, same clothes, same time, the 3 years for daily weights. And also do skin and mouth care. We now look at water intoxication. This happens when hypotonic extracellular fluid shifts into cells in an attempt to restore balance. It happens when hypotonic extracellular fluid shifts into cells in an attempt to restore balance, and the cells will swell. Some of the causes for water intoxication, we have syndrome of inappropriate antidiuretic hormone, or what we call SIDH, rapid infusion of hypotonic solution, excessive tap water, nasogastric irrigation or enemas, and also what we call psychogenic or a dipsia. What are some of the clinical manifestations of water intoxication? Some water intoxication, some signs and symptoms are related to increased intracranial pressure, whereby we have the hurry and red signs. The hurry signs for water intoxication, a patient can exhibit change in the level of consciousness, nausea and vomiting, muscle weakness, twitching and cramping. Red signs, a patient will exhibit bradycardia, widened pulse pressure, seizures, and also coma. Management, how do we manage a patient who has water intoxication? This one, remember, prevention is the best treatment. Always remember that. Assess the neuro status of this client, very important. Monitor intake and output and also the vital signs. Restrict the fluid intake. Ensure these patients have their intravenous access. Do daily weights. Monitor sodium levels. And initiate seizure precautions.
Well, we will now look at electrolytes, and these are charged particles in a solution. Electrolytes can be positively charged, which we call cations, or negatively charged, the anions. Electrolytes are an integral part of metabolic and cellular processes. Positive electrolytes, which we call cations, are like sodium, potassium, calcium, and magnesium. Negative electrolytes, which we call anions, they are chlorides, bicarbonates, phosphates, and sulfates. Major cations, we have the one found in extracellular space is the sodium. Sodium is the major extracellular cation, and potassium is a major intracellular cation. So we will discuss electrolyte imbalances, and these imbalances depend on whether there is more of these cations or anions or less of them. For example, we can have hyponatremia when there is less sodium, or hypernatremia when there is excess sodium. Hypokalemia, low potassium, and hyperkalemia, high potassium. Hypomagnesemia, low magnesium. Hypermagnesemia, high magnesium levels. Hypocalcemia, that is low calcium levels, and hypercalcemia, high calcium levels. hypophosphatemia, low phosphates, hyperphosphatemia, high phosphate levels. So let us start with sodium. Sodium, as we said earlier, is a major extracellular cation. It attracts fluids and helps preserve fluid volume. Sodium combines with chloride and bicarbonate to help regulate acid-base balance. The normal values for sodium is 135 to 145 milliequivalents per liter or 135 to 145 millimoles per liter. Common food sources of sodium include bacon, frankfurters, lunch, meat, butter, cheese, canned food, ketchup, mustard, milk, processed food, snacks, food, soy, sauce, and even what we normally use or frequently as table salt. What is this relationship between sodium and water? So if sodium intake suddenly increases, extracellular fluid concentration also rises. Increased serum sodium increases thirst, and therefore there will be release of antidiuretic hormone. Remember, we said when there is fluid volume deficit, that is when there will be increased antidiuretic hormone release from the posterior pituitary gland. And this triggers kidney to retain water. Aldosterone also has a function in water and sodium conservation when serum sodium levels are low. So let us reflect on something called the sodium-potassium pump. Sodium, as we said, is abundant outside the cells, tries to get into the cells, and the potassium, which is abundant inside the cells, tries to get out of the cells. So the sodium-potassium pump maintains normal concentrations of sodium and potassium. This pump uses adenyl triphosphate, ATP, magnesium, and enzyme to maintain sodium-potassium concentrations. Pump prevents cell swelling and creates an electrical charge, allowing neuromuscular impulse transmission. So when the sodium levels are low, below 135 milliequivalents per liter or millimoles per liter, we will have hyponatremia. Hyponatremia causes water to shift into intracellular space, leading to cell swelling, what we call edema, and decreased serum osmolality, and also we have increased urine osmolality. This condition is as a result of sodium loss through one, use of diuretics. We have diuretics like Lasix, which is also known as furosemide, and thiazides like HCTZ. When you have kidney disease, adrenal insufficiency, for example in Addison's disease, aldosterone deficiency leads to renal sodium loss. Sweating can also lead to hyponatremia. You lose a lot of sodium through sweating. Also burns, where you lose significant amount of fluid, there is also loss of sodium. In that spacing, and this is a shift of fluid from the intracellular, that is inside the blood vessels, into interstitial or that space. This is the non-functional areas between the cells. Also vomiting, you lose sodium. You can lose sodium through diarrhea. Also bladder irrigation. During transurethral resection of the prostate, that procedure, the solutions that are used are highly hypotonic, causing dilutional hyponatremia. Also, when you use enemas, the tap water enemas can cause hyponatremia from free water. The clinical manifestations of hyponatremia are primarily neurological symptoms like headache, lethargy, muscle twitching, cramping, altered mental status like confusion, dull sensorium. Dull sensorium is inability to think clearly and concentrate, anxiety, stupor, seizures, coma, and increased ICP. Hypovolemia, whereby you have poor skin turgor, weak pulse, and tachycardia. Another manifestation of hyponatremia, in hypervolemia, you will have edema, hypertension, weight gain, and bounding pulses. In the GI, gastrointestinal, you will have anorexia, nausea, vomiting, diarrhea. Hyperactive bowel sounds also will be found in hyponatremia. Then in the musculoskeletal system, muscle twitching and spasms, abdominal cramps, body weakness, and decreased deep tendon reflexes. How do you manage hyponatremia? In a mild case, restrict fluid intake in case of dilutional hyponatremia. In hypovolemic hyponatremia, in case of burns and dehydration, whereby there is low fluid, there is fluid volume deficit, you give IV fluids that increase sodium for this kind of hyponatremia, that is a hypovolemic hyponatremia. And in severe cases, infuse hypertonic sodium chloride solution, that is 3% or 5% sodium chloride solution. You can use furosemide, that is Lasix, to remove excess fluid, and also monitor client in ICU. And while in ICU, monitor very closely the neuro status and correct imbalance slowly due to the risk of cerebral edema. Hyponatremia precipitates lithium toxicity in a client taking lithium. Remember, lithium is a mood stabilizer and it is used to treat conditions such as mania and bipolar disorders. Clinical manifestations of hyponatremia, you need to think of acronym SALT. S for skin that is flushed, A agitation, will have L low grade fever, and T thirst. Then there are neurological symptoms such as restlessness, agitation, lethargy, drowsiness. Patient could go into a coma and have stupor. Then there will be signs of hypovolemia, and in this case there is hypotension and weak pulses. When there is hypervolemia, you will have edema, hypertension, and bounding pulses. Decreased urinary output, dry mouth, twitching, cramps, and weakness. Those are the clinical manifestations of hyponatremia. How do you manage hyponatremia? Number one, you start by correcting the underlying condition. Then gradually replace the fluid. That is, hypotonic IV fluids may be used to correct the water deficit. Diuretics to correct sodium excretion. Then monitor for signs and symptoms of cerebral edema. Monitor serum sodium levels and initiate seizure precautions. In hyponatremia, monitor for signs and symptoms of cerebral edema. This is now life-threatening. So monitor for cerebral edema, monitor the sodium levels very, very closely, and initiate seizure precautions.
Let us now look at potassium. And here we will be discussing what happens when potassium is very high in the body, and also what happens when potassium is low in the body. We'll also look at the normal ranges for potassium in the body. And when I speak about the normal ranges of potassium in the body, I'm talking about the potassium in the serum, or potassium in the blood. It's not the potassium in the cells. The serum levels is what I'll be talking about when I talk about the normal ranges. Potassium is an intracellular cation and is a major intracellular cation. Potassium is important in cell metabolism, cardiac function, and neuromuscular function. Untreated changes in potassium levels can lead to serious neuromuscular and cardiac problems. The normal potassium levels in the body or in the blood or in the serum should be between 3.5 milliequivalent per liter to 5.0 milliequivalent per liter. Some of the common food which are very rich in potassium, or some of the foods where we can get potassium, are avocados, bananas, cantaloupe, oranges, strawberries, tomatoes, carrots, mushrooms, spinach, fish, pork, beef, wheat potatoes, and ricin. These are common food sources where we can get potassium from. We now discuss hypokalemia. Hypokalemia, this is when potassium is low in the body. And hypokalemia, we basically have serum potassium levels below 3.5 milliequivalent per liter. What are some of the causes of hypokalemia? We have gastrointestinal cirrhosis. This can be through NGT sanctioning, vomiting, or diarrhea. Another cause for hypokalemia can be insufficient intake, where we can have Grind's swell on NPO, poor diet, anorexia nervosa, bulimia nervosa, and also alcoholism. All this can lead to hypokalemia. Another common cause of hypokalemia is when a client is using potassium wasting drugs, or what we call for examples of these drugs, we have non-potassium sparing diuretics. Here we have thiazide diuretics, and we also have furosemide. Also, when a patient is using laxatives, these are drugs where we have the patient excreting a lot of potassium and can lead to hypokalemia. Also, when a patient is also using corticosteroids, those are some of the causes for hypokalemia. What are some of the clinical manifestations for hypokalemia? When I talk about clinical manifestation of hypokalemia, here I'll give you an acronym. B, thinking of the word sanction. Sanction, just write the word sanction. S will stand for skeletal muscle weakness and fatigue. Skeletal muscle weakness and fatigue. U will stand for prominent U wave. That's a EKG change associated with potassium, specifically hypokalemia, and a highly tested NCLEX question. The NCLEX buzzword for hypokalemia with EKG is prominent U wave. You can look at the chart where I'm pointing about the prominent U wave. You can see the EKG, you can see the prominent U wave after the shallow T wave. There is where we have the prominent U wave. Remember that for the NCLEX. That's the NCLEX buzzword for hypokalemia. We have C for constipation, ileus, and abdominal distension. T, we stand for toxicity of digitalis glycoside. What I basically mean by that is that the risk for digoxin toxicity increases in a patient with hypokalemia. Remember that. I is for irregular, weak 3D pass. Patients with hypokalemia also present with weak, irregular 3D pass. O is for orthostatic hypotension. We also find this with hypokalemia. N is for numbness, where we have paresthesia and also decreased deep tendon reflexes. Remember that with hypokalemia, and that's the clinical manifestation. Just think of sanction. Then, right there, S, as we have seen, skeletal muscle weakness and fatigue. U for prominent U wave, that then NCLEX buzzword for hypokalemia. C for constipation, ileus and abdominal distension. T for toxicity of digitalis glycoside, or what we call digoxin. I for irregular, weak 3D pass. O for orthostatic hypotension. N for numbness, or what we call paresthesia, and also decreased deep tendon reflexes. How do we manage hypokalemia? Management of hypokalemia. The potassium levels are low in the body. Increase dietary intake of potassium. Remember the food sources which are very rich in potassium. We have given avocado, we have seen some of the common food sources we have is avocados, bananas, tomatoes, strawberries. Remember all that. We can also do oral potassium supplements. We can also do IV potassium replacement. We can change potassium sparing. We can change the diuretic that we are using in this patient. Instead of using potassium wasting diuretics, we use potassium sparing diuretics such as ardactone. We also have to monitor EKG changes. Remember, with hypokalemia, we have prominent U waves, so this patient has to be on telemetry. Remember, we said that with hypokalemia, we increase the risk for digoxin toxicity. So if this client is on digoxin, don't give it old digoxin. Also, implement for prevention. Remember, this patient, they have muscle weakness. With decreased with fatigue. They have skeletal muscle weakness with fatigue. So implement for precaution since these clients have muscle weakness and they are also fatigued. An important thing to note is that we have to monitor the client closely for signs of a potassium imbalance, since a potassium imbalance can cause cardiac dysrhythmias that can be life-threatening. Always remember that also in management. We have talked about intravenous potassium replacement. How do we do it? We mix well when adding to an IV solution bag, and also when giving this IV potassium. Remember, the concentration should not exceed 40 to 60 milliequivalent per liter, and the rates are usually at 10 to 20 milliequivalent per hour. An important point to note when doing IV potassium replacement is that potassium is never administered by IV push. Never give potassium by an IV push, intramuscular or subcutaneous routes. IV potassium is always administered using an infusion device, and you have to dilute it. We now look at hyperkalemia. Hyperkalemia, it's hyper, so the potassium is high. The serum potassium levels are above 5.0 milliequivalent per liter, and this one can be caused by heart and kidney function. It can also be caused by increased intake of potassium. Hyperkalemia can also be caused by burns and diabetic ketoacidosis. This one's linked to that spacing, which can lead to hyperkalemia. It can also be caused by hypoaldosteronism, or what we call Addison's disease. It can also be caused by blood transfusion. Some medications, such as potassium-sparing diuretics, for example, ardactone, can lead to hyperkalemia. Angiotensin converting inhibitors, for example, enalapril, can also lead to hyperkalemia. It can also be caused by cell and tissue death, or what we call trauma. What are some of the clinical manifestations associated with hyperkalemia? We have patients with hyperkalemia present with these signs and symptoms: irritability. They also have paresthesias. They also present with muscle weakness, especially the legs. We also see EKG changes with hyperkalemia. Remember tall peaked T wave, that the NCLEX buzzword for hyperkalemia. You can see from my EKG the tall peaked T wave. Remember that. These patients also present with irregular pulse. They also present with hypotension. They also present with gastrointestinal signs and symptoms such as nausea, abdominal cramps, and diarrhea. How do we manage hyperkalemia? Hyperkalemia, if it is mild, give diuretics such as Lasix. You can also do dietary restriction. Restrict the diet. Don't allow the patient to eat foods which are very rich in potassium. Moderate hyperkalemia, we can give Kayexerate, which is an enema, which will give us an enema, and it will allow the excretion of potassium. Emergency management of hyperkalemia, we manage when it is in the emergency situation, we give 10% calcium gluconate for cardiac effects. And we also do sodium bicarbonate for acidosis. Remember, an important point, we have to monitor the serum potassium levels closely when a client is receiving a potassium retaining diuretic. Monitor potassium serum levels closely when a patient or a client is receiving a potassium retaining diuretic such as adonactone, spironolactone, all those are potassium sparing diuretics.
We now look at the other electrolyte known as magnesium. Magnesium is stored in bones and cartilages, and it helps produce ATP, adenyl triphosphate. There's the energy required in cells. Magnesium is very important in protein synthesis and carbohydrate metabolism. It helps in cardiovascular system function during vasodilation, also helps in muscle contraction, and it is directly related to calcium. So when you have magnesium levels below 1.5, that is what you call hypomagnesemia. And above 2.6, it is hyper. A lot of magnesium in the body, hypermagnesemia. So common food sources of magnesium are like avocado, canned white tuna, cauliflower, green leafy vegetables such as spinach and broccoli, milk, oatmeal, wheat bran, peanut butter, almond, peas, pork, beef, chicken, soybeans, potatoes, raisins, and yogurt. Now let us look at hypomagnesemia. We have said that hypomagnesemia is serum levels of magnesium below 1.5, hypo, low magnesium levels, caused by poor dietary intake, poor gastrointestinal absorption, excessive GI and urinary losses. The patients at high risks of hypomagnesemia are those having chronic alcoholism, those with malabsorption, GI and urinary system disorders, they are at risk of hypomagnesemia. Patients with sepsis and burns lose magnesium. Wound needing debridement. If a patient has a wound that will require a lot of debridement, they lose potassium. Clinical manifestation of hypomagnesemia, mostly the GI will have nausea, vomiting, abdominal cramps, anorexia, and dysphagia. The CNS will present with altered level of consciousness, and the patient can have seizures, confusion, and hallucination. In the neuromuscular system, we can have muscle weakness, tingling sensations, leg and foot cramps, increased deep tendon reflexes in hypomagnesemia. We can have tetany and numbness. In the cardiovascular system, it presents with torsades de pointes. You can see from the chart there in an ECG what is torsades de pointes. That kind of abnormal wave. It's like a tornado in the heart. We also have tachycardia, hypertension, and other ECG changes. From the chart, you can see the torsades de pointes wave. That is very important for the NCLEX exam. How do you manage hypomagnesemia? If it is a mild case, just do a dietary replacement. You can also give magnesium hydroxide orally. In severe cases, you give IM or IV magnesium sulfate. IV or IM magnesium sulfate. What are you supposed to monitor when you're giving this medication? Monitor the neural status of the patient. Monitor the cardiac status, and also consider safety. We have seen that this is a patient who can develop seizures. So monitor for the safety of the patient. So when you're giving magnesium sulfate infusion, you need to use an infusion pump, and you cannot give faster than 150 milligrams per minute. So you are giving it slowly, no faster than 150 milligrams per minute when you are using infusion pump. Monitor vital signs for hypotension and respiratory distress. Patients on magnesium sulfate usually develop respiratory distress, slow breathing rate. So if you can find a client on magnesium having a breathing rate of 10 breaths per minute. When you have 10 breaths per minute, what do? Discontinue magnesium sulfate and give the antidote, which is calcium gluconate. Monitor serum magnesium levels every 6 hours, and the patient should be on cardiac monitoring. That is very, very important. Monitor for respiratory distress. If it is there, give the antidote, calcium gluconate. And also, the patient should be on continuous cardiac monitoring. Let us now look at hypermagnesemia. This is serum levels above 2.1 milliequivalents per liter, and the renal dysfunction is the most cause. If you have a problem with your kidneys, it will lead to hypermagnesemia. Examples are renal failure, Addison's disease, adrenocortical insufficiency, and untreated DKA. Then excessive dietary intake of magnesium can lead to excessive dietary intake of magnesium can lead to hypermagnesemia. Too many magnesium containing medications. There are medications that have a lot of magnesium. If you take a lot of them, you can end up with hypermagnesemia and overcorrection of hypomagnesemia. We said in hypo, we give magnesium sulfate. If we give a lot of it, you end up in a hypermagnesemia state. Clinical manifestation of hypermagnesemia, we have neurological symptoms, drowsiness, lethargy, coma. Neuromuscular generalized body weakness, hypoactive deep tendon reflexes, decreased deep tendon reflexes. Remember, in hypomagnesemia, we had increased deep tendon reflexes. In hypermagnesemia, we have reduced deep tendon reflexes, shallow breathing, and slow reflexes. Hypermagnesemia, everything is slow. Even the breathing goes down. That is why you remember we said you have to monitor for respiratory distress and give calcium gluconate. In cardiovascular, you have bradycardia. It's again low, hypotension, and flushed and warm skin. In the GI, occasionally there is nausea and vomiting. Management of hypermagnesemia. 1. Increased fluids in renal function if the renal function is normal. If the renal function is normal, patient doesn't have a renal disorder that is making the kidney to behave in an abnormal way. If the renal output is normal, just increase fluid intake so that it can help in excretion of excess magnesium. Hold any fluids and medication containing magnesium. Loop diuretics if no response to fluids. If an increase in fluids does not lead to lowered magnesium levels, use loop diuretics such as Lasix, furosemide. Calcium gluconate is used for magnesium toxicity. I told you that's the antidote for magnesium sulfate. Mechanical ventilation for respiratory distress. If the patient goes into respiratory distress, the breaths per minute have gone so low, below 10. Consider mechanical ventilation and give oxygen. And then you can consider hemodialysis. with the magnesium-free dialysate. This one is to help remove excess magnesium from the body.
We now look at calcium. Calcium, 99% is in the bones and 1% is in the serum and soft tissues, and is measured by the serum calcium. Calcium, it works with phosphorus to form bones and teeth. It also plays a role in membrane permeability. Calcium is controlled by parathyroid hormone and vitamin D. It has an inverse relationship with phosphorus. Calcium, it also affects cardiac muscle contraction. It's also very important in coagulation. It participates in blood clotting. The normal values, these are the levels of calcium in the serum or in the blood. It's normally 9.0 to 10.5 milligram per deciliter. Some of the common food sources which are very rich in calcium, we have currants, cheese, leafy greens such as kales. We have milk, soy milk, rhubarb, sardine, tofu, yogurt. All these are some of the common food sources for calcium. Let us now look at hypocalcemia. Hypocalcemia, here we have serum calcium levels below 9.0 or below 8.9 milligram per deciliter, or ionized calcium levels below 4.5 milligram per deciliter. Some of the causes for hypocalcemia is inadequate intake. They can be caused when a client is not having adequate intake of calcium in the body. They can also be brought about by malabsorption. We have celiac and Crohn's disease. Pancreatitis can also cause hypocalcemia. Thyroid or parathyroid surgery can also cause hypocalcemia. Renal failure, low diuretics, low magnesium levels in the body. Hyperphosphatemia can also lead to hypocalcemia. Vitamin D deficiency, alcoholism, and also bulimia nervosa can lead to hypocalcemia. What are some of the clinical manifestations of hypocalcemia? Neuromuscularly, we have anxiety, confusion, irritability, muscle twitching, paresthesias. That one can happen in the mouth, fingers, and toes, and also tetany. Then Craig's one for hypocalcemia in the neuromuscular system. We have Chef-Sotek sign, which is a contraction of facial muscle in response to a right tap of the facial nerve in front of the ear. We also have the Trousseau sign, which is a carpal spasm induced by inflating a blood pressure curve above the systolic pressure for a few minutes. For the purpose of your NCLEX, remember the Chef-Sotek sign and the Trousseau sign. We have fractures. With the hypocalcemia, we also have fractures. Remember, a client with a calcium imbalance is at risk for a pathological fracture. So you have to move this client carefully and slowly, and also you have to assist the client with ambulation. They can easily develop fractures. You also have diarrhea. You also have diminished response to digoxin. Those are some of the clinical manifestations associated with hypocalcemia. We also have some EKG changes which can develop in hypocalcemia. When the serum calcium levels are below 8.9 milligram per deciliter, on the EKG, we will have a reddened ST segment. We will also have a reddened QT segment, and may cause torsades de pointes. Although torsades de pointes is more common with hypomagnesemia. How do we manage hypocalcemia? Do calcium gluconate for post-op thyroid or parathyroid client. Cardiac monitoring. Remember the EKG changes with hypocalcemia, so we have to do EKG monitoring. You can also do oral or IV calcium replacement. Remember, aluminum hydroxide reduces phosphorus levels, causing the counter effect of increasing calcium levels. You can give that one with hypocalcemia also. You can also do vitamin D, which can aid in the absorption of calcium from the intestinal tract. Remember those 2 points also. We now look at hypercalcemia. Hypercalcemia is when we have the serum calcium levels above 10.5 milligram per deciliter, or ionized calcium above 5.1 milligram per deciliter. Some of the causes for hypercalcemia, it can be caused by cancer of the bones or metastasis of the bones. It can also be caused by hyperparathyroidism, immobility, and use of glucocorticoids. Some of the clinical manifestations for hypercalcemia in the neuro, the patient will present with symptoms of fatigue, confusion, lethargy, and coma. Neuromuscularly, this patient will present with muscle weakness, flaccidity, and hyporeflexia, or what we call decreased deep tendon reflexes. Cardiovascularly, this patient will present with bradycardia, cyanosis, and deep vein thrombosis. In the GI, or what we call gastrointestinal, these patients will present with anorexia, decreased peristalsis, nausea and vomiting, decreased bowel sounds, and constipation. These patients can also present with polyuria, renal calculi, or what we call kidney stones, and also renal failure. How do we manage patients with hypercalcemia? If they are not presenting with any symptom, just treat the underlying cause. Do cardiac monitoring. We can give IV fluids. Mostly normosaline is the preferred one to encourage diuresis. Encourage oral hydration. Encourage the patient to drink orally these fluids. You can also give root diuretics. You can also give corticosteroids. You can give calcium binders, and for very severe cases, do dialysis.
We now look at the other electrolyte. Phosphorus is an important electrolyte. It's the primary anion in the intracellular fluid. It is crucial in cell membrane integrity, muscle function, neurological function, and metabolism of carbohydrates, fats, and protein. It also has a very big function in ATP formation, that is the form of energy that is required in the cells, in phagocytosis, that is engulfing of microorganisms, especially bacteria, by the white blood cells, in the platelet function and formation of teeth and bones. It has an inverse relationship with calcium. What does this mean? It means when the calcium is high, phosphorus is low. When the phosphorus is low, the calcium is high. Inverse. The normal values for the phosphorus is 3.0 to 4.5 milligrams per deciliter, or 0.97 to 1.45 millimoles per liter. We have common food sources for the phosphorus. These include dairy products, fish, nuts, pork, beef, chicken, organ meats, pumpkins, squash, whole grain, breads, and cereals. So when the potassium levels are low, that is a hypophosphatemia. And we normally say when the serum phosphorus levels are below 2.5 milligrams per deciliter. This can lead to organ system failure, and it's usually caused by respiratory alkalosis, that is when there is hyperventilation, insulin release, malabsorption, nutrition, total parenteral nutrition, diuretics, DKA, elevated parathyroid hormone levels, and extensive burns. That's where we have hypophosphatemia. A decrease in serum phosphorus levels is accompanied by an increase in calcium levels, and an increase in serum phosphorus levels is accompanied by a decrease in serum calcium levels. This is a reciprocal relationship between calcium and phosphorus. What we said earlier is inversely related. We now proceed and look at clinical manifestations of hypophosphatemia. In the musculoskeletal system, we have muscle weakness, respiratory muscle failure, osteomalacia, and pathological fractures. In the CNS, central nervous system, we have confusion, anxiety, seizures, and coma. Cardiac, there is hypotension, decreased cardiac output. And hematologic, the patient is prone to hemolytic anemia, easy bruising, and infection risk. The management of hypophosphatemia, if it is mild to moderate, just do dietary interventions, diet low in calcium, and phosphorus-rich diet. You can also give oral supplements of phosphorus. In severe cases, IV replacement using potassium phosphate or sodium phosphate. Hyperphosphatemia. This is when serum phosphorus are above 4.5 milligrams per deciliter. This can be caused by impaired kidney function, cell damage, hypoparathyroidism, tumor lysis syndrome, respiratory acidosis, DKA, and increased dietary intake. Clinical manifestations of hyperphosphatemia. When the phosphorus are high, you can think chemo. This is cardiac irregularities. There will be cardiac arrhythmias, hyperreflexia, eating poorly, that is a lack of appetite, muscle weakness, and oliguria. How do you manage hyperphosphatemia? You give a low phosphorus diet, decrease absorption with antacids that bind phosphorus. There are antacids that bind phosphorus. You decrease to decrease the absorption of phosphorus. You treat underlying cause of respiratory acidosis or DKA. Also give IV saline for severe hyperphosphatemia in patients with good kidney function. For severe hyperphosphatemia, give IV saline for patients with good kidney function. Now let us look at active transport system. And here we said it requires expenditure of energy. It's also called pumping. We have come to the end of electrolyte imbalances. We have tackled the sodium, potassium, magnesium, calcium, and phosphorus. Those are important. They can be tested on NCLEX. It is good to have a good understanding of these electrolyte imbalances. Something maybe we can reflect is the electrocardiographic changes in electrolyte imbalances. Just to recap, we said hypocalcemia, there is prolonged ST segment, prolonged QT interval, and shortened ST segment. That is hypocalcemia. In hypercalcemia, we have widened T wave, ST depression, shallow, flat, or inverted T wave. In hypokalemia, we said prominent U wave and tall peaked T waves. That is very important. Tall peaked T waves in hypokalemia. In hyperkalemia, we have flat P waves, prolonged PR intervals, widened QRS complexes, and tall T waves. Hypomagnesemia, we have depressed ST segment and prolonged PR interval. In hypermagnesemia, we have widened QRS complexes. It's good to remember these ECG changes, because they can also be tested on NCLEX. It's good to know where we have tall peaked T waves in hypokalemia and widened QRS complexes or prolonged ST segment. It's good to have a good grasp of such content.
We have now come to the end of our fluid and electrolyte topic. It is a high yield NCLEX topic. You won't miss 1 or 2 questions on this. And as usual, we'd like to test your knowledge using a sample of NCLEX style questions. Remember to subscribe to our channel, NCLEX Made Simple. Also invite your friends who are struggling with this topic for fluids and electrolytes to have a watch. We have tried to summarize as much as possible and to only cover the content which we normally see highly tested on the exam. All the best as you do this NCLEX style question to test the level of your knowledge and understanding. Thank you for your time and cooperation.